everyone. Thank you, Dr. Norsey. I'm delighted to be here to welcome you to the Women's Health Conference 2021. And before we get started, in light of recent announcements, I think it's fitting that we acknowledge Dr. Francis Collins and his leadership at NIH through the years. His commitment to women's health and women's health research has allowed us to implement policies that ensure that sex is considered in NIH-funded research and clinical trials. And we wish him all the best in his future endeavors. I also want to begin by thanking and acknowledging members of the Coordinating Committee for Research on Women's Health, NIH's CCRWH, and the Advisory Committee on Research on Women's Health, and many others for their assistance in gathering the information that has been curated and leading up to today's meeting, and for raising important questions that have helped inform future directions for women's health research. Next slide, please. As you heard from Dr. Norsey, this meeting is a result of a congressional request, and Congress is so important to ORWH. In fact, it was almost 31 years ago that another congressional request concerning the lack of inclusion of women in clinical research was followed by the formation of ORWH. So ORWH certainly welcomed this congressional request on what research is currently being conducted and contemporary gaps in knowledge about the health of women. We see this congressional request and this Women's Health Conference as another launching point for a robust future centered around women's health. And the request shows that more attention is being given to women's health at the highest levels of our government, a welcome step forward. I always like to acknowledge those that came before here, and you can see them depicted on this slide. Next slide, please. We know that women's health is critical to our nation's health. However, we need more women enrolled in clinical trials and more females in preclinical research. Next, we're moving away from a default human model of a small woman being seen as a small man. Next, and attitudes related to paternalism, protectionism, and inappropriate emphasis on the menstrual cycle. We're moving away from preponderant use of male animals in preclinical research. Next, that resulted in a unidimensional picture. Next, and we generated knowledge that applied really only to males, so we know far less about female biology. There's several women's health milestone moments that I'm just highlighting a few of them here where progress has accelerated. In 1993 with the NIH Revitalization Act, directing the establishment of guidelines for the inclusion of women and minorities in NIH-supported clinical research. Fast forward to 2016 with the 21st Century Cures Act, requiring NIH to find applicable phase 3 clinical trials to report their results disaggregated by sex, gender, race, and ethnicity into clinicaltrials.gov for the very first time. And of course, efforts related to implementing the NIH policy on sex as a biological variable, where we now expect NIH investigators to account for SABV in their research designs, analysis, and reporting for vertebrate, animal, and human studies. And in 2016, NIH's research condition and disease categorization reports now publish inclusion data by sex, gender, race, and ethnicity. Next. This particular request comes at a most timely moment. It's coinciding with the new 2021 to 2025 NIH-wide strategic plan, which recognizes women's health upfront as one of the six cross-cutting themes. And this is an important time. And at this point, we know that women's health research commitment is a relatively small portion of the overall NIH budget. And as we look forward to addressing gaps in knowledge, we see a future where all of the 27 institutes and centers efforts related to women's health research are working in a collaborative and coordinated manner to advance science for the health of women. Next slide. To get to today, we had broad input through paths that converge along the way. ORWH did a lot of work in that space. Next, we started with an RFI that solicited public input. Next, and given this task, we worked with our coordinating committee, formed a Women's Health Conference Planning Committee, and heavily engaged that CCRWH as well as our advisory committee, creating a Women's Health Conference Working Group. We also included and engaged subject matter experts and SMEs from across NIH, as well as the Department of Health and Human Services, including ex officio federal employees who are representing CDC in particular, FDA, CMS, HRSA, and the VA. These subject matter experts were separated into several clusters to review the NIH portfolios on women's health research in the 3 specified areas. With their help, we categorized the most prevalent diseases and conditions into 4 areas for further study by our working group clusters, and summarized recent research trends and the current state of NIH-funded research and gaps in current women's health research topics. Within these working groups, the clusters, the current state of NIH-funded research and recent research trends were summarized. We also identified perceived gaps in that portfolio, and our findings were shared with the advisory committee's working group, who created today's agenda, invited noted speakers on fields of women's health who will provide their perspectives on compelling public health needs, gaps in knowledge in areas that are crucial to improve the health of women, and opportunities to strengthen the NIH Women's Health Research portfolio. The ACRWH Women's Health Conference Working Group will also present their findings and results of today's discussions at tomorrow's ACRWH meeting, and I invite you to join. Excuse me, the committee will be prioritizing opportunities for the future of research on women's health at the NIH and summarizing these in a report that will be returned to Congress in December. We're excited to share these findings with you today as we lead up to our final report. Knowing where we are today helps us to identify future opportunities. Next slide. So as I mentioned, back in 2016, NIH implemented the SABV policy, laying the foundation for the framework you see depicted here in this slide. Next, we see that incorporation of considerations of sex and gender across the research continuum, from preclinical through translational and clinical research, we see that as a critical guiding principle for the future of biomedical research. Next, by doing so, we advance rigor, drive innovation, and apply equity, exponentially expanding the impact of research and truly turn discovery into health for everyone. Next. So some of the steps along the way are depicted in the slide. On the bottom, you can see sex analysis and sex-specific reporting. We know that's critical, and fewer than 1/3 of phase 3 clinical trials report their results disaggregated by sex. And we see how that effort is important for informing interprofessional health education, healthcare, and health policy. Next slide, please. We are particularly excited about the focus on lifespan research, which was also articulated in the NIH-wide strategic plan. Next, because it's one of the strategic goals of that plan. And next, because we have been advocating for a life course perspective from the very beginning of ORWH's founding. We see this multidimensional framework that's depicted in the NIH-wide strategic plan for women's health research, and we put forward the notion that internal factors such as biology, SABV, for example, external factors, women's health in context in the lives that women lead, are so important to considering the health of women. And we realize that today it's the intersection of a multitude of factors that culminate in our health and our well-being. Next, this life course perspective accounts for, and next, key stages of a women's lives, recognizing that ill health at certain stages can have long-term effects beyond those periods. In a sense, these time periods can offer a view into future health and are therefore windows of opportunity to intervene. Next, we think of pregnancy as a stress test, and this slide graphically depicts how pre-existing health of women before they become pregnant can portend the future health of women, as we see women's health as from a multi-system perspective, from head to toe, inside and out, and through an integrated life course lens. That multi-system perspective speaks to how systems are connected, for example, hypertension and mental health. And that integrated life course perspective also speaks to viewing each encounter as part of the life course of that woman in the context of what came before and what will come after. Integrating research across the life course has the potential to drastically improve women's health. If pre-pregnancy health is better, pregnancy would be safer, and if postpartum health and women were linked to primary care in an integrated and coordinated fashion, we would have a better chance of taking advantage of the window of opportunity that when pregnancy reveals susceptibility to type 2 diabetes, for example, with a new diagnosis of gestational diabetes or a diagnosis of preeclampsia portending increased risk for cardiovascular disease. We now know that within 3 years of that preeclampsia diagnosis, we are seeing rates of hypertension. So that is something we want to see improve in the future. Menopause is certainly another special window with accelerated risk and an opportunity to intervene and have women lead their best lives as healthy as possible. We know that women do live longer than men, but women also live more years with chronic disease and with disabilities and debilitating status. So we want to expand that health span so that the lifespan is equal to the health span. And we are always interested in working across silos and sectors in a complementary manner with partners who share that vision as appropriate. Next slide, please. As we think about redefining chronic disease in women, what constitutes advancing science for the health of women, and reprioritize how we think about research in this space, we are seizing this moment to advance the health of women. We ask a couple of questions. How do we move beyond just policy and programs to drive fundamental change? What checks and balances need to be built into the research ecosystem? How can we incentivize cross-sector innovation to drive discovery? And most importantly, for everyone here today, what part are you going to play? Whole person perspectives and approaches are sorely needed in research and biomedical research. Mental health cannot be overlooked. The role of trauma and violence are critically important and shape our health in meaningful ways. Linkages between heart disease, anxiety, and depression, obesity and depression and subsequent cardiovascular disease risk are just some of the multi-system perspectives that need to be taken into consideration for us to advance science for the health of women. How we do science needs to change. The need for interdisciplinary research is something that ORWH has been advocating for from the beginning, and the potential to bring disparate and complementary expertise to bear on a problem, convergent science approaches are what we see for the future as the best ways to advance science for the health of women. I'm so excited to be here with you today, and I look forward to the rest of our program today. With that, you can also connect with ORWH at all of the opportunities listed here on the slide. Sign up for our e-learning courses, follow us on social media, and receive our quarterly and monthly publications.